So now getting back a little bit more to the outline that we had laid out before, the first question was really, how do you make decisions about surveilling a patient versus intervening surgically? And like you'll find with pretty much any medical condition that a physician takes care of, what you're really doing is putting together a puzzle to figure out what the best, what the most accurate diagnosis is and what the most appropriate treatment is. So there's clinical pieces, there are imaging pieces, and there are potentially physiologic testing pieces that you can put together to come to a conclusion around these things. So the classic clinical pieces when you're evaluating a patient for Chiari malformation are headache is number one. So, is the headache occipitally located? Is the headache, as I mentioned before, is it a tussive headache? Is it an inducible headache? Is it an intense headache that comes on really strongly when you cough and then goes away really quickly? So intense, short lasting. Those are sort of your classic textbook headaches that can be treated by surgical decompression of a Chiari if a Chiari is present. When people have migraines headaches, when they have cluster headaches, when they have frontal headaches, those aren't going to get better with treatment of a Chiari, even if they do have a Chiari. So it's really critically important that you hone in and you recognize the details of headaches that can actually be treatable with our therapies for Chiari. Other things that are really common in terms of the clinical findings with patients with Chiari are, neck pain, myelopathy, which that's usually going to come along with a Syrinx or something like that. Lower cranial nerve deficit, so that can come along with brainstem compression, and that can manifest as swallowing problems, sleep apnea, snoring, things of that nature. So those are sort of the clinical pieces that you're looking for. Periodically, you'll even see things like eye movement abnormalities or loss of reflexes. When it comes to imaging, obviously MRI scan is going to be the standard. And, as we talked about before, you're looking for 5 millimeters of cerebellar tonsillar herniation, although I'll talk about that in a little more detail in a minute, because increasingly the position of the OBEC seems to be perhaps correlated more closely with actual symptomatic Chiari. One of the things that we see is there are a lot of people out there who have Chiari malformations by MRI criteria. Many of them are not symptomatic and don't require intervention. So that's one of the big pieces in terms of what we do. When you think about Chiari 2, obviously vermis herniation, do you see a Syrinx on an MRI scan? And then do you see scoliosis? And that's really best assessed with just a standard, upright X-ray. So those are sort of the imaging features that you're looking for when you're putting this puzzle together. And then in terms of things like physiologic testing, you can get sleep studies. So it's not uncommon that I get a referral for a patient with a Chiari that's identified because they came in with a sleep problem. They had a sleep study that showed central sleep apnea. That prompted the ear, nose, and throat physician, for example, to get an MRI. Boom, they've got a Chiari and they come over to see me. So those can be really useful adjuncts in terms of diagnosing whether or not someone needs intervention, whether or not they're truly symptomatic. So you say, okay, I've got these puzzle pieces and I'm going to put them together, but how do I know when I put them together whether I should do surgery or recommend surgery or whether I should recommend observation or something else? So I think this sort of conventional wisdom, the way that I was taught and have practiced, is that you can kind of think of it as two buckets of patients. So you have patients who have symptoms and patients who don't have symptoms. So among the ones who have symptoms, what are the symptoms that lead you to say, okay, surgery is the right thing for this patient. I can make this patient's life better by doing surgery. And so if they've got headaches that are really mild, maybe they have them like once every few months and they're not that bothersome, well, do you really want to go through an operation in order to potentially treat that headache? Maybe not. But if you have headaches that are really impacting your quality of life, that are preventing you from doing things you want to do, that may be a circumstance where you do surgery to try to treat those headaches. And that, again, is kind of the most common reason why people present with symptomatic Chiari. And I also mentioned before some of the other symptoms. So myelopathy, if you've got central sleep apnea, things of that nature are clearly symptoms that can be related to the Chiari and that can be either halted or reversed if you do surgery to decompress the Chiari. So those patients very often will merit an operative intervention. Then you have a group of patients who don't have symptoms, and there are still some who benefit from having surgery. So a patient who may have a progressive, albeit asymptomatic scoliosis, that's somebody where if you potentially intervene appropriately, you can prevent them from having a continuing progressive scoliosis, and you may be able to prevent them from needing to have a spine fusion, for example. Similarly, a progressive Syrinx, like the patient you see in this picture, she's basically asymptomatic. Over the course of a few years, she's had this progressive Syrinx. And is that someone who you think, well, maybe it's time to do a decompression on this patient. And then you get into sort of the risk benefit ratio associated with the surgery and intervening for something that is asymptomatic at the time.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.